everyone, and welcome back to the Child Death Review and Prevention Conference. We're just getting straight into the second session, which is around classification of sudden infant deaths. And we have quite a few presentations this afternoon, so we'll get straight into it. This session will explore how classification algorithms can help to better identify unsafe sleep factors and suffocation in infants. It explores the importance of understanding airway protection in safer sleep messaging and product safety regulation. The first presentation has been pre-recorded for us today by Dr. Sharyn Parks from the National Center for Disease Control and Prevention in the United States. It's quite exciting for us to get a presentation from overseas. Sharyn's presentation talks to the classification and identification of accidental suffocation within the US Sudden Unexpected Infant Death Case Registry. Please play Sharyn's presentation. Thank you.
Good afternoon. My name is Sharyn Parks, and I am pleased to have the opportunity to speak with you today regarding the United States Sudden Unexpected Infant Death, or SUID, Case Registry and Classification System. I'll also share with you how we've used the classification system to discern, describe, and estimate risk factors for different types of SUID. Before I get into the content, I do want to provide a quick disclaimer that this presentation represents the work of myself and my co-authors and is not an official position of the U.S. Centers for Disease Control and Prevention. Sudden unexpected infant death, or SUID, is a common cause of infant mortality. There are approximately 3,400 sudden unexpected infant deaths in the United States each year. This is defined as the sudden unexpected death of a baby less than 1 year old in which the cause was not obvious before an investigation. These often occur during sleep or in the baby's sleep area, so are sometimes referred to as sleep-related infant deaths. And this includes those from sudden infant death syndrome, or SIDS, and other undetermined causes, as well as accidental suffocation and strangulation in bed. And though there were declines in the rate of these deaths in the United States following the recommendation to place infants on their backs to sleep in the early 90s, the rate of these tragedies has remained fairly stable since the early 2000s. Differentiating explained SUID from unexplained SUID can be challenging because, again, most of these are occurring during sleep and are often unwitnessed events, which can make determining the exact circumstances and the role of hazards in the sleep environment difficult. To address limitations of traditional vital statistics-based surveillance of SUID, and to help increase our understanding of the true burden and factors associated with sleep-related infant deaths, CDC supports the Sudden Unexpected Infant Death Case Registry, which is a multi-jurisdictional, population-based surveillance system and is built upon the established child death review programs in our participating jurisdictions. The goals of the registry are to conduct population-based surveillance in U.S. states and jurisdictions, to monitor trends and describe the demographic and environmental factors of the deaths, provide information that can help improve death investigations moving forward, and also to ultimately inform prevention activities and reduce infant death rates. Another goal of the registry is to categorize SUID cases using a classification system and standardized algorithm that was developed specifically for the registry. We created the CDC SUID classification algorithm to facilitate consistent and objective evaluation of cases by providing a standardized grouping method to allow for consistent monitoring of SUID, to account for unknown and incomplete investigation information, which can inform improvements to case investigation, and to acknowledge uncertainty about how suffocation or asphyxiation may or may not have contributed to deaths. The SUID classification algorithm also allows for calculation of population-based incidence for each type of SUID based on the standardized grouping, thus allowing for more consistent comparisons of different types of sleep-related infant deaths. It is important to note, however, that the classification system was not intended to reclassify the official cause of death. To illustrate the utility of the classification system, I'd like to share an overview of a paper published in the journal Pediatrics in 2021 called Explaining Sudden Unexpected Infant Death. This study aimed to differentiate unexplained from explained SUID using the SUID case registry. We applied the strict set of criteria from the classification algorithm to over 12,000 registry cases that occurred from 2011 to 2017. We analyzed deaths from 18 SUID case registry states and jurisdictions, and based on review of variables contained in the case registry, trained registry staff classified SUID cases into 6 mutually exclusive categories using CDC's SUID classification algorithm. And the categories were explained suffocation with unsafe sleep factors. Then we had unexplained categories as follows: possible suffocation with unsafe sleep factors, unsafe sleep factors, no unsafe sleep factors, incomplete case information, and no autopsy or death scene investigation. Cases that were classified as explained or possible suffocation with unsafe sleep factors were also assigned one or more mechanisms to which the airway obstruction was attributed, which we'll talk more about in a little bit. So you can see that the age at death in months follows what we typically see for sudden unexpected infant deaths. And 90% of these deaths occurred during the first 6 months after birth, with a peak between 2 to 4 months of age. As is typical for SIDS and SUID, that was more common among males, with 58% of deaths occurring among male infants. And when we compare our registry cases to the birth population among participating jurisdictions, we found that non-Hispanic Black and American Indian Alaska Native infants are overrepresented among the SUID cases. For instance, non-Hispanic Black infants represented 16% of the birth population in the 18 states and jurisdictions in our data, but 36% of the SUID from those jurisdictions were Black. When we consider all of the cases together, unsafe sleeping circumstances were all too common. Overall, we found that 72% of SUID occurred in unsafe sleeping circumstances. We found that cases classified as unexplained, unsafe sleep factors constituted the largest proportion, so 40% of the unexplained categories. These were deaths where there were known unsafe factors in the environment, but that for which we don't have evidence of anything having obstructed the infant's airway. Thus, the cause of death remains unexplained. Less than 1 in 5, so 18% of SUID were explained as suffocation deaths. Although these explained deaths constitute a small proportion of SUID, these deaths are nearly always preventable. And about 1 in 8 were classified as possible suffocation. And these deaths may also largely be preventable. Among the explained and possible suffocations, the majority, so about 3/4, were attributed to soft bedding, having occluded the infant's airway. The second highest proportion of cases were those 27% that were classified as incomplete information. This group is a combination of 2 algorithm categories. Incomplete case information, which consists of cases where there wasn't enough information documented from the investigation to tell where and how the baby was found. And the second category is those cases that were missing a death investigation and/or an autopsy altogether. So what's the significance of these findings? Explaining how and why SUID occur is critical to understanding the etiology and reducing the risk of future infant deaths. Unsafe sleep circumstances were common among SUID cases, but the data that were available to us could only explain why the death occurred in about 1 in 5 cases, so those that were classified as explained suffocation. Understanding the mechanisms that contribute to suffocation deaths and the frequency at which they occur is critical in forming effective prevention strategies as well. We also conclude from the findings in the study that more thorough investigations and autopsies can help determine the role of intrinsic factors such as cardiac channelopathies, genetic abnormalities, or even seizure disorders, and or extrinsic factors like prone sleeping position, soft bedding, or shared sleep surface in causing infant deaths. It's also important for us to consider how social determinants of health impact access to or receipt of screening for intrinsic factors and the ability of families to adhere to extrinsic preventive factors. So the need to collect data that can help elucidate that is critical. Our other takeaway from this study is that our classification appears to do what we had hoped. It allowed for consistent objective classification, and it also improves the consistency of our surveillance and our understanding of epidemiologic trends in SUID. There were some limitations to our study to mention. Classification depends on the accuracy and completeness of information collected. For instance, all information from medical legal reports may not be captured in the registry. Also, investigation is frequently complicated because most SUID, again, are unwitnessed events, and evidence can be compromised during resuscitation or transport. And then technical assistance and resulting improvement in data quality associated with participation in our case registry limits the generalizability of our findings beyond the states and jurisdictions that participate. Also, participation in the registry varied over time, which limited our ability to examine trends. So what are the suggested actions aside from continued use of the classification system to understand and improve data? First, we know that more than 70% of cases were found in an unsafe sleeping environment. Thus, safe sleep recommendations were not being followed. We need to improve our understanding of the reasons for non-adherence to the recommendations, like lack of knowledge or financial barriers, and then identify methods to address these factors. We're also increasingly realizing the importance of exploring social determinants of health and how they impact families' access to and receipt of screening for intrinsic factors, as well as their ability to adhere to extrinsic factors, which may increase risk for sleep-related death. Second, we've come a long way with regard to infant autopsy and death scene investigation and documentation, but continued improvements are critical to further improving our understanding of sleep environment's role in infant deaths. This can be achieved by addressing some of the training and resource needs that have been identified within the medical legal death investigation community. And thirdly, we noted that 18% of cases in this study reported recent illness and or injury. So these are infants who may have had recent contact with a health provider, potentially representing additional opportunities for receipt or reinforcement of safe sleep messaging. Thus, it's really important that every infant encounter be viewed as an opportunity to teach and re-emphasize the safe sleep basics. Next, I'd like to talk a bit about the next paper we worked on. So once we had a good sense of the applicability of the classification system over time and a detailed characterization of how SUID were grouped into categories and mechanisms, our next undertaking was to look really closely at the group of SUID which were explained suffocation, because this is the segment for which we are confident in the cause of death. And we view this group as the most urgent to address in terms of prevention. Thus, we undertook a study to examine risk factors for this group alongside those for unexplained SUID. So this study, entitled Risk Factors for Suffocation and Unexplained Causes of Infant Death, was published this past January in Pediatrics. We again used the CDC SUID classification system to identify SUID that were either due to sleep-related suffocation or unexplained causes. And then we examined risk factors for sleep-related suffocation and unexplained infant deaths independently of one another. To accomplish this, we conducted a population-based case control study using infants born during 2016 and 2017. The cases, again, were from the case registry, and then we had live-born infant controls from CDC's Pregnancy Risk Assessment Monitoring System, also known as PRAMS. The study population consisted of infants who resided in Alaska, Delaware, Louisiana, Michigan, New Jersey, New Mexico, and Wisconsin, which are states participating in both the SUID case registry and PRAMS. PRAMS provides a representative sample of live-born infants from the participating states and jurisdictions. The control group in a case control study is selected to provide information on the exposure distribution in the population that gave rise to the cases. The comparison group or controls should be representative of the source population that produced the cases. The source population is the population that gives rise to the cases included in the study. So by using PRAMS, we had a representative sample of live births. The live births were the at-risk population for SUID. In this case control study, it's important for the controls to be sampled in a way that is independent of the exposure, meaning that the selection should not be more or less likely if they have the exposure of interest. We created a state representative pseudo-population of controls to represent all registered live births in each of the included states. To do this, we duplicated each PRAMS record by its corresponding PRAMS person weight. Then, from the pseudo-population of over 600,000 live births, we randomly selected 4 living controls for each case. Controls were then matched to cases on infant age, so age at death for cases, age at the time of survey completion for controls. We calculated prevalence for 5 primary exposures, being sleep position not on back, soft bedding use, sleep surface type other than a crib or bassinet, sleep surface sharing, and not sharing a room with a caregiver during sleep. We estimated risk by calculating exposure odds ratios for both outcomes, so that's suffocation and unexplained death, after controlling for potential confounders. The confounders that we included were those that were previously identified as risk factors for SIDS, including the demographic and maternal variables shown here. We found that after adjustment for the demographic and maternal factors, the magnitudes of risk for suffocation and unexplained deaths differed. Non-supine sleep was associated with 1.9 times the risk of suffocation and 1.6 times the risk of unexplained death. Soft bedding use was associated with 16 times the risk of suffocation and 5 times the risk of unexplained death. We had a fairly large confidence interval for the estimate of suffocation risk, and it did overlap with the confidence interval for unexplained death. Infant sleep location on a non-approved surface, something other than a crib or bassinet, was associated with 4 times the risk of suffocation, but no increased risk of unexplained death. Again, note the confidence interval for risk of unexplained death crossed 1, so this wasn't statistically different. The infant sleep area not being in the same room as a caregiver was associated with 19 times the risk of suffocation and 8 times the risk of unexplained death. Here again, we had a pretty wide confidence interval around the point estimate for suffocation risk that overlapped with the estimate for unexplained death, meaning you cannot rule out the possibility of the point estimates being the same. But the important piece here is that there's a huge increase in risk of dying. Infant sharing a sleep surface was associated with 3 times the risk of suffocation and 2 times the risk of unexplained death. Here again, the confidence intervals around the point estimates for suffocation and unexplained death overlapped, meaning you cannot rule out the possibility of the point estimates being the same. So to summarize all of these findings, the magnitude of risk associated with sleep environment factors were generally larger for suffocation. The magnitude of risk associated with soft bedding and not room sharing were more than twice as large as the risk for unexplained death. The confidence intervals for the estimates of suffocation risk associated with both soft bedding and room sharing were pretty large, likely due to the smaller cell size for the suffocation group as compared to the unexplained death group. But the large difference suggests a likely clinically meaningful difference that warrants further examination. Non-approved sleep surface was associated with suffocation, but not unexplained death. Not room sharing was shown to be a risk factor for both suffocation and unexplained death. These findings were unique because prior studies, including prior case control studies, have not examined risks associated with suffocation separately from unexplained death. There were some limitations to this study as well that I'd like to mention. There was the potential for social desirability and non-response bias in reporting sleep practices for cases and controls. Because most SUID deaths are unwitnessed, as I've mentioned several times, there are limitations in how much data on the circumstances of death are missing. And finally, the results may only be generalizable to the 7 case registry and PRAM states included in the study. To put this information into practice and incorporate into safe sleep education, consider that the risk for sleep-related suffocation may be a concept that's easier for parents and other caregivers to understand than risk due to unknown causes. Also, risk factors are not created equal. It's important to ensure that SIDS education and safe sleep promotion programs address the riskiest factors. So from our study, we see that those highest risk factors were soft bedding and non-room sharing. I'd like to conclude, as I do every presentation, by re-emphasizing the safe sleep basics, so ensuring baby's in a crib on his or her back with no soft bedding, and have baby share your room but not your bed. I'd also like to thank all of our partners shown on this slide, and thank you again for the invitation to speak with you today and for your time.
Q&A session, so we have got that scheduled for the end, which is at 2:30 at this session today. Obviously, that was a pre-recorded, and so if you do have any specific questions for Sharyn, we can obviously make contact and try and seek them out, but it may just take us a little while to close those out for you. Moving straight on to the next presentation. So next up, we have Dr. Julie McEniery and Dr. Diane Cruice from the Queensland Paediatric Quality Council, and they are presenting on the development of the Safer Infant Sleep Clinical Guidelines. Over to you, Di and Julie.
Thanks very much, Jamie, for the invitation. I'm very pleased to present with my colleague Diane Cruice today on behalf of the Quality Council on our pathway to developing some infant safer sleep guidelines, which was based on concepts very similar to the ones that Sharyn has presented about making it easier for infants to sleep. And that came from reviews that we had done of sudden unexpected infant deaths. So I would like to just start by paying respects to the traditional custodians on the land of which we are meeting today, the Yagara and Turrbal people, paying our respects to Aboriginal and Torres Strait Islander elders past, present and emerging. So this wasn't just an academic interest to us. We have a higher infant mortality in Australia than the rest of, in Queensland than the rest of Australia. Looking at deaths per 100 live births and rate ratios, taking all the jurisdictions in Australia except Queensland as the rest of Australia group. So these are two discrete populations, and we used rolling 3-year averages. And you can see the difference in the infant mortality rates between Queensland and the rest of Australia. And there's an average of around about a 20% higher IMR in Queensland. We weren't sure how big a contribution SUID was making to infant mortality and whether opportunities for prevention would make a difference. And one of the barriers to understanding the extent of preventable cause of death is the cause of death coding, which is so imprecise. Just as example, this is taken from the Australian Institute of Health and Welfare website, and it shows two issues. First of all, well, it doesn't show the relative proportions of death. It just shows them ranked in orders 1 to 5. But you can see on that top line where I've pulled out just the infants and year ones. You can see, as if they were discrete conditions, other ill-defined causes, sudden infant death syndrome and accidental threats to breathing. And yet we've just heard from Sharyn, and certainly from our own work, we know that these really are part of a spectrum, and it's very difficult to differentiate. Still, using the ABS data, the ill-defined category R95 to R99 on the ICD-10 codes, we've had a higher sudden unexpected death in infancy from ill-defined cause in Queensland for many years. And even though that has narrowed a little, it is still a significantly different result with a rate ratio of 0.42. And then from a recent study of all Queensland infants born alive after 22 weeks over a 6-year spread, 1,400 deaths. And just looking at the cause of death, we have our answer to the question, how many are sudden unexpected deaths? In the neonatal age range, they're very much perinatal and congenital, but certainly in the post-neonatal deaths, the acquired cause is the most dominant cause. And of those, there's this subset of ill-defined cause deaths, which is comprise the majority of the deaths. So we have our answer to whether or not preventing some of these deaths would make an impact. So our process in the Quality Council is that we have an infant mortality subcommittee, and we receive linked infant data from statistical services, and also, and from that we identify deaths referred to the coroner. And then we get records for the mother and for the infant requested from hospital and health services, and the coronial records. And 2 members individually from this expert panel subcommittee, they review the documents and complete an online data form, and then we present the cases at a monthly meeting and develop consensus. And this is our committee, just to give you an idea of the hard work from all these clinicians and other experts who donate their time pro bono. So just to present some data from the 2013 to 2015 cohort. So we received the final coronial reports for these in 2020, if you're wondering about the delay. Some of these processes take a long time. But we identified 239 post-neonatal infant deaths and 576 neonatal deaths. From the neonatal deaths, we selected the neonatal SUID by looking at the coronial records and looking at a cohort of records. But we looked at all the neonatal deaths, all the post-neonatal deaths, because we weren't certain whether just a high-level view would tell us whether or not they were truly SUID. And from that review, we ended up with 132 post-neonatal non-SUID deaths. And this is our study population here in the blue of neonatal and post-neonatal SUID, 125. And then we were looking at sleep-related deaths from these 125, the majority occurred apparently during sleep, 116, although 4 of those were due to fatal inflicted injury. And then there were another 9 where we were uncertain if they were asleep. They might have been breastfeeding or found moribund. But it did leave 112, which was the majority of SUID, which occurred in sleep. And so therefore the sleep circumstances were possibly relevant. And we divided these into infants who were shared sleeping with an adult or other person and the infants who slept alone. I'll go through these data, but I will show a graph that explains them if you're having trouble seeing So we identified 8 different SUID risk factors. We didn't consider shared sleep in and of itself as a risk factor. And we compared shared sleep with infants who slept alone just to get a feel for which factors were predominant. And we were very much interested in position place to sleep, but we created a variable called adjusted position place to sleep. Now, I'll just take you through the journey to get there. We worked further on the initial work that was done by our colleagues, Roger Bayard and Rebecca Shipstone and Janine Young, who used lividity over the anterior surface of the body or over the face to adjust the position to having must have been prone when the circulation stopped. That was the position found. But we went a step further and said, well, if the baby was found prone and the baby was too young developmentally to roll, the baby must have been placed prone. And so when we did those 2 things, looked at anterior or facial lividity and then looked at the developmental age of the infant, we found that up to, or just a little over 70% of infants who slept alone could be considered to have been placed prone, whereas only 30% were stated to be placed prone. We didn't adjust for shared sleep because we reasoned that an adult turning in the bed could easily passively cause an infant to roll. And so, of course, the supine levels took the journey in the other direction. So another unsafe sleep position for the SUID who slept alone was being positioned head up or propped or on an incline, with nearly a quarter of them in that position. And Diane mentioned further while we're so concerned about that as a sleeping position. Another unsafe position in the shared sleeping was the infant sleeping in the adult's arms and then the adult falling asleep. Thick soft bedding was a huge risk, over 2/3 in both categories, and sharing sleeping with adults affected by prescribed or illicit drugs or alcohol was another risk factor. And then smoking in pregnancy was well above the Queensland average of only 15%. And there were infants who were found after sleeping on an unsafe sleep surface, a surface not intended for sleep, but they were in the minority. So what that means is that our sleeping factors, and we've included smoking in this because it affects the way the infant responds during sleep, particularly soft bedding, being placed prone, an inclined position, and unsafe positions with a co-sleeper were the ones that we focused on. And then when we looked at the whole group, we discovered that, unfortunately, in the shared sleep group, over 40% didn't have all the details that we needed listed in their police investigation. The investigation was much more precise for the SUID who slept alone. Regardless of whether factors weren't mentioned, still almost 100% in both group had unsafe sleep factors. You remember Sharyn mentioned 75%, but we were in the 90% range for both. And so you can see the discrepancy between shared sleep and slept alone, where there was documentation of sleep factors, but certainly the unsafe sleep factors were incredibly high. So final closing categories, and again I'll show you a graph that explains this, but we started off with most of the SUID having been officially categorised as SIDS, and then relatively equal numbers of natural cause and undetermined cause, and very few aspiration. And our final categories completely flipped those, and so we ended up with natural cause and SIDS dropping to very low levels, and the undetermined category and the accidental suffocation increasing a great deal to 22%, which is a ballpark similar to Sharyn, who mentioned theirs was 18%. So just wanted to finally focus on this suffocation, or on the reclassification. We didn't, as I say, we didn't use shared sleeping as a standalone risk factor, but we were interested if we were biased and we were somehow more willing to recode deaths from shared sleep versus deaths when the infant slept alone. And the blue here is the shared sleep infants, and the purple is the infants who slept alone. And it's interesting that there wasn't really any difference between the two groups, but in both groups, the number of natural cause deaths reduced and SIDS, and in both groups, the number of undetermined cause increased and accidental suffocation increased. And then finally, just on the accidental suffocation, we found in 18 of the 112, there was a real possibility of suffocation. The infant was described as being face down on an object or up against an object, either a person or a piece of bedding. But it wasn't sufficiently described as being pressed into that object, and we couldn't sort of exclude that the baby was somehow resting on its little nose and perhaps still had a preserved airway. And then we found another 41 of 112 infants where we thought there was probable suffocation. In 26 cases, the infant face was pressed into a soft surface. In 3 deaths, the infant was said to have been overlaid by another person, but there was no recording about where the face was in that overlay. And then in 12 deaths, the infant face was covered by thick bedding. We don't just mean a sheet, we mean, thick adult doonas. And so really well over half these infants, we thought there was either a possible or probable suffocation, but we finally coded these as suffocation in only 19 of these probable causes. That's only 17% of the SUID during sleep. And those were the cases where we had enough of a scene description to be able to be, a reasonable level of certainty, and where there was a complete post-mortem, so other causes were ruled out. So we use this information to inform prevention, and I'll hand over to my colleague Diane now to take us on that journey.
Thanks very much, Julie. If you want to just progress to the next slide. So the information that we used, we wanted to inform the development of our new safer infant sleep guidelines. However, just waiting for the slide to come up. As Sharyn pointed out in her talk previously, it's not just a matter about having guidelines, it's how we know what we know about parents are doing generally in the community, but also how do we get those messages across? And we were very lucky to have some great information, not only from the SUID deaths in Queensland, but also Queensland Infant Care Practices study, which I'll talk about in a moment, and some great work on how do we get those messages across. I'm not going to go into a lot of detail about the exact specifics of what's in the guidelines in terms of content, but if you need to find them, you can easily Google Queensland Clinical Guidelines, and we're there under neonatal guidelines. You'll find the Safer Infant Sleep Guideline. Thanks, Julie. So what did we know about what Queensland parents were doing in terms of sleep situation? Well, thanks to Dr Ronnie Cole and Professor Janine Young from the University of the Sunshine Coast, they conducted the Queensland Infant Care Practices study. I'm not going to go through all of the information in detail, and there is certainly a lot more information in these studies, but just wanted to point out that obviously not the safe sleep guidelines or the things that are suggested as the key messages are often not being followed by parents in their day-to-day caring for their infants for various reasons. Just want to point out these last 2 points, that 55% of mothers place their babies in an inclined position if they have concerns about reflux, and that over 20% had used a pillow with their infant at some point. Thanks, Julie. The other things that we wanted to get a look at were communicating with caregivers, and thanks to Anna Peace and her colleagues in the UK who did a large review in this area and found that interventions can't be just a one-size-fits-all. They have to take into perspective the parent's perspective, their circumstances and their experiences. And also Middlemiss and her colleagues in the US found that behaviour was more likely to change when there was an understanding of what the risk was or why there was a risk, rather than just being told to put your baby on your back. And they also recommended a GIST format. So GIST is where you summarise things very succinctly into one neat message for parents to easily be able to understand. And then Stephanie Cowan and the Change for Children team in New Zealand put together a fabulous education package as part of the PepiPod program, where they relied heavily on this type of communicating with parents, and they coined the phrase easy to breathe, safe to sleep, which resonated hugely with our working group, working through the guides. And Stephanie was very gracious in suggesting that we continue to use that phrase not only within the guides, but to really use it wherever we could to, I guess, bring to life their next GIST message was to share your knowledge and protect all babies. Thanks, Julie. So the actual guideline development was quite structured. We did it in collaboration with the University of Sunshine Coast, Professor Janine Young in particular, and Queensland Clinical Guidelines, who have this role of guideline development happening all of the time. Our clinical lead group was Julie, Janine and myself. We had a working party of 105 people in the end, so a large range of professionals across the state. We also had GP representatives, we had consumers, and we had members of peak bodies such as Red Nose, Australian Breastfeeding Association, Australian College of Midwives, just to name a few. Our working party actually went through 2 complete reviews of the guide because it changed so much between one and the other. We then went to statewide consultation for more feedback and incorporation. The guide was endorsed by the key councils and networks for maternity and paediatrics in Queensland and finally released in July last year. Thanks, Julie. Just to give you an overview of the guides, the key safe messages are still there and are still important, but we're really wanting to capsulate that within a risk management approach and how we communicate to caregivers. So we have a whole section on communicating with caregivers and what's recommended. Sorry, Julie, just sit. Thank you. We also focus a lot on mechanisms of airway protection, which was something we hadn't seen so specifically in a lot of guides, but it really was to talk about this, as Sharyn mentioned, and also Julie, how do we talk to parents about keeping babies' airways safe to reduce this risk, this real risk of suffocation in the sleep space? And then finally, within the guides, there are lots of specific strategies for safer infant sleep for clinicians to use with families. But really only once we've got this key message across, we've communicated it well, and we feel that everyone's understanding how to protect infant airways. Thanks, Julie. So obviously within this session, we're focusing on the mechanisms of airway protection, which was just summarised there, but I'll go on to it in more detail. For example, on the next slide, we have within the guides, what we've tried to do is encapsulate the risk factors in succinct forms in tables so that clinicians aren't wading through lots of information to get to what they need, but also in a way that can help them understand and relay that to parents. So this was just one table about the mechanisms of SUID in the infant sleep space, and I couldn't resist putting this Facebook ad with it, where the quote actually says, "Did you know that babies have an off switch?" which is quite ironic in this situation. So the number of risk factors in that advertising picture there, I'm going to leave for Ruth in our next presentation to go through because she has some doozies, certainly. Thanks, Julie. We also, when we looked at things such as supine sleep position or sleeping your baby on your back, this is in every safe sleep messaging, but we really wanted clinicians and therefore parents and caregivers to understand that it's not just placing your baby supine helps make babies safe, but that placing them non-supine actually increases the risk of SUID and how that increases the risk of SUID rather than just believing that that is so. So we covered that as well. Thanks, Julie. Next one. We were very fortunate to be able to use the data that we had in Queensland, both the SUID reviews that we had done and also the work of the Infant Care Practices Study to know that incline position was a real issue. We had around 25% of our deaths were found in a propped or inclined position, or not found, but had been placed to sleep in an inclined or propped position. And our reviewers really drilled down to how they felt this contributed. And it was sometimes because the infant had slouched down into more of a C-shaped position, compromising breathing, or had fallen forward or rolled forward onto a pillow, even though they'd shown no ability to roll previously. So we have a little video here that shows a little baby propped on a pillow quite nicely, thinking that they're all safe and ready to go to sleep. And with a bit of movement, their heavy heads tend to cause them to roll forward. Now, if that happens in the middle of the night and no one is there to rescue that baby, their face is generally pressed down into the bedding. Thanks, Julie. We also have quite a section on shared sleeping and safer shared sleeping, because we know that a lot of families, I think around 80 to 90%, will share a sleep surface with their baby at some point, whether they intend to or not. And as Julie mentioned, it's not so much the act of the shared sleeping, it's the environment in which the shared sleeping occurs. And is it the safest one possible for the baby? We put this into a model which included looking at different levels of care that parents need, but we adapted a 5A model in terms of to work with for our midwives and our child health nurses in terms of identifying what different sorts of families would need at each level. So obviously our universal need is asking all parents about shared sleeping and whether they intend to, how it looks, what can they do. And then secondly, in the next circle, we have additional needs. So those families that need a bit more support, a bit more of a plan, a direct plan, or what to do when things don't go quite right. And then finally, our families with significant needs who may need significant support to actually arrange a safe sleep space for their infant, including programs for priority populations, which may not even have a safe sleep space for their infant. So, for example, we just have a picture here of the PepiPod program being used. So this just gives you an example of a type of program that can be used when we're looking at families that are really high risk. And the majority of the reviews that we do would fit in that significant need or additional need. So a lot of our families where SUID is occurring are the families that need that level of support. Thanks, Julie. And one last thing I wanted to mention was that the guide actually incorporates a section on infant development and SUID. We found a little group of infants, well, not such a little group, but around 6 to 9 months of age who were becoming entangled in their bedding and found totally entangled in doonas and big blankets and things. So we wanted to include a section for clinicians to be aware that SUID just doesn't sort of finish at 4 to 5 years of age when babies can start to move around and push up and crawl. In fact, the risks become more intense in other aspects of their sleep environment. So we really wanted to include a section on that. Thank you. And then lastly, just to say that we've used this information to look at other things as well, not just the safe sleep guidelines. We've done a review of the PepiPod program in terms of its impact on population infant deaths in Queensland, and found it did make a real impact, a huge impact in those communities where it was used. So we're now working towards trying to get that as a program that can be used around Queensland. We've been working closely with the Coroner's Court of Queensland and our state coroner to look at improving SUID investigations so we can address some of those areas that are missing when we're trying to actually work out the preventative factors in these cases. We've also been working with the Queensland Police Force in terms of a first responders guide in helping police and ambulance recognise what is needed to know to help improve the investigation. And finally, newsletters and other publications from the QPQC to look at the particular risk factors in SUID to get the message across to all clinicians. And thank you. Thanks very much.
So much. I know how much effort's gone into the development of those guidelines, and so it's quite an achievement to get them published and so on. So congratulations on that. Right, up next we have Dr. Ruth Barker. She's from the Queensland Injury Surveillance Unit, and she will be talking very similar theme of safer infant sleep by looking at the product safety guidance for those products. So over to you, Ruth. Oh, we're just having a little technical glitch. If you just bear with us a quick second. Over to you, Ruth.
Okay, hopefully everyone can hear me. So thank you very much for that presentation, Julie and Di. Now, having heard about how and why infants are vulnerable during sleep, and how families can promote safe sleep through behaviour and product selection, I'd like to talk to you a little bit about how the industry and marketing affects the choices that parents make. So how does product design and marketing and regulation influence infant sleep practices? There are a myriad of products for sleeping, settling, soothing, and transport of infants, and infants sleep sometimes for a prolonged period of time in all of them. And this is a global market, and yet regulatory approaches vary between jurisdictions. So KidSafe Queensland, in collaboration with a range of other health industry and research partners, developed what we call a best practice guide for the design of safe infant sleep environments. The first thing to say is that it's not just about the cot. A safe sleep environment is the sum of many parts, combinations of products and practices that are to a large extent beyond the control of the individual product designer or supplier. Therefore, coming up with a guide that addresses product-specific risk associated with infant sleep needs to be set within the broader context of infant sleep behaviours, such as we've just heard about. So whether the sleep occurs in a designed infant sleep product, such as this one, depends on the choices that parents make. Those choices can be considered and planned months before a baby arrives or forced by circumstance. Best made plans are often abandoned, and despite best intentions, we often end up on the couch or in a hastily arranged co-sleeping situation. And I have to say that this dog of mine, Winter, she's a Swiss Shepherd, is currently sleeping in the cupboard behind me, which is also quite improbable if you realise how big she is. It's important to realise that there are products marketed for every situation. So the principle of this guide is that regardless of the situation, the product range on offer and the marketing of that product should be developed with a firm understanding of what makes a sleep environment safe. However, mixed messaging is a huge issue. Products are often marketed with messaging that conflicts with or contradicts health messaging. One of the common issues is conflicting verbal and visual messaging. So this baby beanbag is not a sleep product. In Australia, it's required through legislation to have a warning label stating that it is not suitable as a sleeping surface for infants. It is not specifically marketed as a sleep surface, but as a transportable device for soothing infants. Note that it has a restraint system allowing or encouraging periods without direct supervision. And yet the advertising images clearly show a sleeping infant in a compromised chin on chest position. The risk of the product is further compounded by the fact that beans settle and compress over time, and that the buyer has an option to buy the bag flat packed and fill their own product. And this can lead to underfilling of the product and further compound poor positioning of the infant. Back to the womb is a marketing strategy that appeals to our desire to comfort and coddle our infants. And I suspect the success of this marketing strategy varies across global markets, as there are some practices designed to build resilience in babies, such as what's called lufting the baby or airing the baby, which is common practice in Denmark, where they bundle the babies up in the pram and leave them out in the cold to sleep. Still, there are many products marketed as being safe and womb-like, claiming that they are the only way to settle your infant. Unlike the womb, these devices do not always support safe respiration. The DockATot and other similar products were originally marketed for soothing and use words like nest and womb. However, as a sleep surface, the risk of suffocation is increased by the soft padding at the sides. The mattress firmness standard AS 8811 was developed in 2013 in Australia, but to date has only been mandated in the US. Unfortunately, that standard is silent on the side elements of the sleeping product. It specifies a firmness test for the horizontal surface only. The US has recently acted to ban crib bumpers over concerns about the suffocation risk created by a padded side element. And presumably as a result, the US DockATot website carries prominent warnings regarding its unsuitability as a sleep surface. However, on the Australian website, I really had to hunt for this. So the safety warning says, never use in a crib, bassinet, or other contained area. Keep away from wall or other vertical structure. Baby can move between DockATot and side structure and become entrapped and suffocate. Use on a flat, firm, stable surface. Never use to carry a child, and never use on a surface from which the baby can fall. So this warning was found only by looking for the safety section right at the bottom of the web page. And even with the warning, the website claims that their product was born out of a long history of co-sleeping practices in Sweden, suggesting that this is a safe co-sleeping device. And the warning does not specifically address the risk of infants sleeping in the product when not placed in the cot. Another strategy that is used to calm and settle babies is swaddling. But what is best practice, and more importantly, what does it look like in the real world? So rather than just comforting infants, swaddling seems to be used to restrict activity, as can be seen in this example. So it says, around 3 months, Molly, my future Olympic gymnast, discovered she could, while tightly swaddled, somehow flip herself over onto her stomach and wriggle backwards out of the swing. The first time I heard a thud and I found her on the floor in front of the empty swing grinning. I thought it was a fluke, but on the third, I had to concede that the days of her sleeping safely in the swing were over. So this baby, tightly swaddled, was habitually placed to sleep in an inclined swing device and yet managed to flip herself out 3 times before the parent conceded defeat. Despite parental perceptions, the swing as an inclined surface was never a safe place for the infant to sleep. And in this instance, the use of swaddling enabled poor practice. Swaddling can also be directly hazardous, particularly when the practice is extrapolated to other sleep situations or locations. There have been deaths associated with swaddling and car restraints, as shown here. Safe use of products often relies heavily on instructions and labeling, but communicating risk and influencing safe practice becomes challenging when products are combined and used by different carers. It is also challenging when images promoting unsafe practice, such as this, are posted by influencers. Health messaging rightly emphasises strategies to support infants to breathe, but many products are promoted with breathability claims that are unsubstantiated and sometimes misleading. Breathability is a marketing term that at present has no clear test method. It's often used when the product is air permeable, but the breathability of a product needs to examine the issue holistically. It needs to address the physiological hierarchy of no face occlusion, patent airways, unimpeded diaphragm, and chest excursion first. This crescent womb product, again marketing the comfort of a womb-like environment, is made from air permeable mesh, and so it's unlikely to directly suffocate the infant if they tried to breathe through it. However, it places the infant in a chin to chest position with a curved back, increasing the risk of airway obstruction and impairing diaphragm movement, and creates other entanglement and fall hazards. And trawling through reviews revealed this post about an infant who flipped prone. So it says, I feel if I'd not been in the room and heard her muffled sounds, she would have suffocated, because unlike a flat crib, they cannot lift their head out of this if flipped on the stomach, like they could on a mattress. So the mothers rightly identified that the baby was unable to extract itself from that particular position. Some years ago, the website had been quoting an old AAP paper about delayed neuromuscular development of a premature infant nursed on flat cot mattresses to substantiate claims that this particular product improved development and reduced flat head in term infants. It also used to claim that crescent womb reduced, and I quote, the environmental risk factors associated with SIDS. After complaints to the CPSC and AAP, crescent womb remains on the market, but the marketing has changed. It now claims, incorrectly I believe, that it adheres to the AAP safe sleep guidelines, and now helpfully says, steer clear of products that claim to reduce the risk of SIDS. It's best to avoid any product that says it can lower your baby's risk of SIDS because they haven't been proven safe or effective. So that's just warning off the competitors. So is breathability a real concept, and might it be important? A breathable design may further reduce sleep-related deaths where an infant ends up prone or with their face against another element of the product and is unable to extract themselves. Therefore, there is likely to be added risk reduction through designing products with breathable zones. But breathability needs to take into consideration things like resistance to airflow, dissipation of exhaled air and CO2, and inflow of fresh air. So this slide represents testing on a range of common sleep environment surfaces, including, most importantly, combinations of products. I'm part of a collaborative team discussing testing methods to assess a combination of mattress firmness, which is represented here inversely as surface displacement in blue, airflow resistance, which is in orange, and carbon dioxide rebreathing, which is assessed as how much exhaled CO2 can be re-extracted from the sleep surface. This is represented in grey. This is early research, but as this graph shows, there is no clear correlation between all factors. And I have to emphasize that this is testing real-life products. However, it seems that in terms of CO2 rebreathing, products with low air permeability, such as vinyl-covered mattresses or waterproofs, and products with very high air permeability, such as mesh surfaces, pose the lowest CO2 rebreathing risk. But these designs would still need to be firm, flat, and level. Unfortunately, product design and marketing outpaces regulation and research, and one example of this is the snoo sleeper, which has been designed by a paediatrician to settle fussy babies by restraining them on their backs. And you can see that this infant has been Velcroed into position with a little thing over his chest. It oscillates them at variable speeds, and I'll demonstrate this in a minute. It plays white noise to them at various levels, and it also allows parents to remotely settle the baby using a smartphone app. So the baby can actually be in the same room or in another room, and the parent can change the setting of the cot without actually attending to the baby. But I have to wonder how side-to-side oscillation compares to traditional rocking through a circumferential arc in terms of the forces on a developing neonatal brain. Are some infants more vulnerable to this movement? What decibel level is appropriate for a young infant? And I'll just start the video. So you can see the infant starts at low oscillation, but this increases later in the video. Then there are reports of the restraint band ending up at the top of the chest, and recommendations apparently from customer service to use weighted items like a bag of rice underneath the restraint system and on top of the baby's chest in order to settle them. This raises the risk of compression of the chest, but also the bag migrating up and occluding the face. So back to the Safe Sleep Guide. The ACCC are currently considering holistic regulation in the infant sleep space, which includes products used to settle and soothe. In particular, they are considering a ban on inclined sleep products, which is very welcome news. However, regulation requires surveillance and enforcement, and it would be better if the products on offer were designed to be safe in the first place. So this guide seeks to preemptively get industry, parents, regulators, and safe sleep advocates on the same page so that parents can buy better and we can all sleep better. The guide can be found on the Product Safety Australia website, and in light of some of the emerging hazards, version 2 will be coming soon. Thank you very much.
Thank you, Susan. I'm sorry, Ruth, sorry. I was looking at Susan at the time. Apologies. Thank you, Ruth. Excellent presentation. That now brings us on to question time and the Q&As. And so I'd like to kick it off, and probably with the kind of biggest, hardest question, which is obviously, particularly in Queensland, the numbers of deaths in relation to SUID are still high, if not higher, the last 12 months. And so, you know, even with the guidelines and the best practice guide, where to from here? Where do you think we can kind of move to? Is it something around community awareness, and what may that look like moving forward? Julie, would you like to start?
Oh, thank you, Jamie. Look, I think there is room room, if not for optimism, at least to acknowledge some encouraging steps. Our whole of government has decided to focus on the first 2,000 days as a priority area, and obviously part of that is infant wellbeing. And this has come at a time with a fusion of quite a few different great ideas in terms of intensive models of care support for the vulnerable mother and her new infant, a more structured approach to child health support, visiting, and messaging. And then, as Di said, on the safer infant sleep aspect, the further uptake of the guides. We're hoping to work on an e-learning package with just snippets, a just-in-time approach, so that health practitioners who are going to talk to somebody for the first time about safe infant sleeping in a shared sleep environment will be able to the idea is that they'll be able to log in and have a sort of a refresher about an approach to take. There are certainly incredible social determinants at work here. Very rare is it that we review a case where there isn't multi-generational adversity. So these are a particularly vulnerable, marginalised population. We have a shocking higher rate of SUID in our Indigenous infants compared with non-Indigenous, but we also have incredibly marginalised non-Indigenous families. We have an idea that this is happening out in the regions. It's happening in the suburbs around our big cities. So, I think we need to take the message, much more to where families are living rather than expecting them to sort of come to a health facility and sort of receive instruction. It needs to be a conversation, and it needs to be on their terms and in the place where they live.
Thank you, Julie. And Ruth, in relation to the products, obviously with the internet and so on, we can purchase things from overseas quite easily. How important a role do you think the ACCC and our local Office of Fair Trading would play a role in trying to get on the front foot with some of those, because some of those come in through the door and don't comply with any of the requirements?
Look, I think the first thing to say is that actually there's surprisingly little standardization in relation to infant sleep beyond cots. There is the mattress firmness standard, but it's not actually mandated in Australia. It's mandated in the US. The minute you are talking about a surface that's not actually the flat mattress, but the rest of the elements in products that infants sleep in, there isn't actually currently a test methodology. And so the group that I'm involved with includes researchers and designers from the States, and they're working with the ASTM committee over there to try to get this issue of what is breathability and how do you test for firmness and how do you test for CO2 rebreathing and how does it all relate together? Because it's very challenging, and the breathability tagline in marketing has just grown like Topsy, and the number of claims around this product is safe and breathable for your infant would really curl your hair. When you look at a product like Crescent Womb that's still on the market, and yet it puts infants in that very compromised position and is still claiming that the air permeability is an important feature of the design. So I think there's a really long way to go. The ACCC has jurisdiction in Australia, but unfortunately it's a global market and you can buy anything over the internet. And so this is why my efforts is focused on engaging with international players in this space.
Thank you, Ruth. And we've got a question around PepiPods and about accessing those. Julie, Diane, do you want to talk briefly about what's happening in Queensland in that space?
I'll let Diane take that one. Jamie, I also noticed a question from Stephanie as well, so perhaps I could take that after Di.
Absolutely.
Yes, so basically we have been pushing since we did our population review of the PepiPod program, because it has well and truly been evaluated in Queensland now. We know from Janine Young's work and the University of Sunshine Coast that it was appropriate, effective, communities engaged with it. It was seen as a First Nations innovation that could be translated into the wider population. So that has all been fantastic. We've managed to really try and promote this through Queensland Health at a recent forum for the health services chief executives. They agreed to support the program in principle and to purchase PepiPods for each HHS. What we need to do now is get the program rolled out around Queensland. We've only been funded for one equivalent of one NG7 nurse, who has just been employed. It's still a long way to go. We need a plan for how this is actually going to work, and it's only for the rest of this financial year and the next financial year. We're working with the first 2,000 days team in the Reform Commission in Queensland Health to look at how we can support this program better to get it rolled out around Queensland. So fingers crossed in the next year or two, it should be something that's widely available to clinicians. It is something that requires training first to implement. It's a train the trainer model. So it's not just a matter of handing out PepiPods. That's when we're looking at it not working and almost being a disaster in some ways. We really need parents and caregivers to be educated on how to use it, but also safe sleep education. It has been found to be most effective.
Thank you, Diane. And just on that last question for you, Julie, which is around given child mortality data custodians are coding and categorizing deaths according to official cause of death information on death certificates, are the learnings from your reclassification being shared with death certifiers to improve the quality of cause of death data within your jurisdiction?
Look, yes, the short answer is we're doing our very best, and we've been blessed with a wonderful collaborative partnership with the Coroner's Court of Queensland, particularly the current state coroner, Terry Ryan. And so as Sharyn Parks Brown said, we're not suggesting this reclassification of death in terms of categorising for research purposes should supplant national statistics coding. And in some ways, the ICD-11 will help that anyway, because as we'll hear this afternoon, the unexplained causes will be grouped together, whether they're SIDS or undetermined. But we're working with the coroner and the pathologist to get a better integrated final summary of the death, so that all aspects of the infant's life and the circumstances of death, as well as the post-mortem, are taken into consideration. And we think that will, at the very least, better identify contributory factors and prevention opportunities. But perhaps also we might have an opportunity to work away a little bit at this very specific reluctance to certify a death as due to suffocation, which implies some parental, or could imply some parental responsibility. And obviously nobody wants to cause greater harm to these families who are very bereaved. But they certainly don't need a criminal level of certainty, criminal court level of certainty here. They just need, reasonable certainty to be able to do that. So we're working away with that, but it's a long project.
Thank you. Look, we have run out of the time, so thank you all so much for that great discussion. We will be taking a short break now and reconvening, I think, at 2:50. So thank you so much, and see you back soon.
Thank you.